I'll be discussing some of the work that I've done, as Dr. Ailey mentioned, with application of this, what we think is an innovative and emerging analytical technique. I will also be demonstrating how I applied this to a large public data set and discuss some of the strengths I noted with this method, and also some challenges, and also suggest some future applications. Throughout the presentation, you'll hear me use identity first and person first language to accommodate for everyone's preferences. As I mentioned a little bit earlier, while everyone was hopping on, my background is in nursing. I've been a registered nurse for 18 years. I'm currently a manager of nursing research at a non-academically affiliated health system, third-year PhD student. I also am a mother, and my oldest child has autism, and that really set me on a path to focus on disability health equity. And as Dr. Ailey mentioned, we both attended a workshop at Rush that was offered over the spring. It's a 4-day workshop, and it followed by a 2-day conference. And since then, I've been trying to apply what I learned and see how it might be applicable for future work. I'll be providing just a high-level overview of this method. Again, because it took us a 4-day workshop just to get a sort of cursory introduction. Since then, I was able to secure a technical advisor, someone who's had much more experience than me. And we've also had contact and have had resources given to us by the person and the team who invented this method. So it's definitely not something that I can speak to with great confidence, because I've at this point have done it once. And certainly anything very, very detailed and technical would require more time for me to try to explain. So this will just be a high-level overview, but there are resources available to dig in a little further. So what coincidence analysis is, it's a type of comparative configurational method, and it's been used for the last 30 years in mainly social and political sciences. This type of, or this subset of a CCM that's called coincidence analysis was introduced in 2009 by a researcher, Michael Baumgartner out of Norway. And it has been gaining traction, particularly in health services research and in implementation research in the last, I would say, decade. What it does, it seeks to identify combinations or bundles of conditions that are necessary and sufficient to lead to an outcome. So it looks for the presence or absence of things in combination with each other, and how that could directly links to the presence of an outcome. How it differs from what we're typically used to with correlational methods, we think regression, those sorts of things, is that it just takes a different theoretical and philosophical approach. It applies different theories of causation. Instead of applying linear algebraic methods, it applies Boolean algebra. And it, again, is looking for bundles of things that must be there in order for an outcome to occur. And I'll explain this a little bit more by showing you this figure. And I apologize, it's a little bit blurry, but on the left-hand side, you see how in most standard methods, we're looking at incremental effects that are averaged over that lead to an outcome. But with this method that's shown on the right-hand side, you look for sets of configurations or bundles. So for example, you can see that, this could be read as factor 1 and factor 6 lead to an outcome, but also factor 5 in combination with factor 4 and factor 3 also lead to an outcome. So that's different than regression. We typically don't see multiple pathways in that way. The other thing that it can reveal to us is chained pathways to an outcome. So if these 3 bundles up here lead to an outcome, it can also show us if this outcome also, if these bundles are also a subset of other bundles that lead to another outcome and to another outcome. So that's kind of the basic premise of how this works. It was very, very challenging to try to wrap my head around this as a student, having just taken grad level statistics courses. This was very, very different. So with that, because it's not included in typical grad level courses, it is very much like learning a foreign language. So it feels like it's a new, at least new to you theory. The theory has been around for a long time. It's new to most people. They use different terminology, different semantics. What we would call sensitivity and specificity, they call, consistency and coverage. They also apply a different way of cleaning and structuring your data. Um, Also, another thing to note with this method is that it cannot be used in some software packages. It can only be applied in R currently. So the person and the team who developed this method have also developed the software application for this. And as a student, I learned SPSS. I kind of dreaded learning R. I'd heard terrible things about it, but I took some online courses and it turned out to be just fine. The nice thing is you don't need to know R intimately. You just need to know it just to a limited degree in order to be able to apply the method. But certainly, if you're looking to do this, you do need an advisor or someone who can guide you through it, someone who's done it before you can become independent in conducting the analysis. So I'll give you some examples of how it's been applied, and then I'll show you how I applied it. I wanted to highlight an article that was published by the person who agreed to be my technical advisor. His name is Edwidge. He's adjunct faculty at Rush, and he currently works at in Indiana. And he did a study looking at Veterans Administration obesity treatment programs. Noted that some of these programs that are intended to offer treatment weren't or had different levels of patient engagement or patient reach, and they weren't able to identify, what's explaining this variation in reach. So essentially, they were measuring program effectiveness. When they applied the method, they noted there were 5 distinct pathways or 5 configurations that combined local context factors and also program components that explained higher patient reach. And with that, they were able to take those results and inform optimal structures for programs in order to maximize their patient reach. Another way that it was applied was through the director of Rush BMO Institute is Dr. Rich, and he and his team looked at combinations of state firearm laws and how those were linked to low firearm suicide and homicide rates. So one of the results showed that low firearm suicide rates could be explained by 3 different pathways, whether a state had the presence of universal background checks or the presence of under 21 firearm possession restrictions or the presence of junk gun bans. And in their article, which I included in my reference list, they did some really nice maps, visualizations to show this, to show which states had low or not low suicide or homicide rates related to firearms. So I thought that was just an interesting application. Certainly, like I said, it looks like it's been picking up steam in terms of health equity. And that's why Dr. Rich, actually, the one who authored this, was the one who helped sponsor that workshop that was hosted at Rush last spring. So a little bit about the project that I conducted was on autism outcomes. So we know there's well-documented health disparities. Less is known about all, the different determinants of health and how those combine with one another to contribute to inequitable outcomes. Because we know there's limited resources to address disparities, it's important for us to know what makes a difference for whom and under what conditions so that we can optimize interventions and tailor interventions to help address those determinants of health. And so I was looking at it to explore these intersections of determinants of health. So I did a secondary analysis, using the 2022 National Survey of Children's Health, again, a publicly available data set. It's a survey that's conducted annually, either web-based or paper pencil, administered by the US Census Bureau. and it asks parents or guardians of children in the US to answer questions about health and well-being. This particular data set had data on over 54,000 children. 1,700-ish of those were children whom the parents reported had a current diagnosis of autism. Each parent or guardian answered over 130 questions on health and well-being. When I opened up that data set, there were over 930 columns of data. So it was a lot of data to sift through. And so I had then the difficult task of trying to choose which factors to take into modeling. This is a copy of a map of the questions, and I won't go over all of this, but I wanted to show you that it does cover nicely lots of different determinants of health. So they're asked about physical health, emotional health, health insurance coverage, access to health, school and neighborhood information, the health of the family, so the health of the caregivers, and it also asks questions related to the coronavirus pandemic. So the outcome variable that I wanted to model was what the parents perceived as far as the overall health status of the child and they answered that on a 5-point Likert scale. I wanted to take the approach of modeling what does good or excellent health look like. I think, we have a good idea of what bad health looks like, but I was interested in knowing what sorts of factors are related to what a parent would perceive as their child having excellent or very good health. And to narrow down the factors, I did a literature review, and I selected 62 potentially relevant factors to take into modeling. And this is the other strength of this approach, is that you can take a lot of variables into modeling, whereas with traditional approaches, you're limited in that. So with CNA, you have 2 different phases. The first phase of it's called the exploratory analysis phase. And this is where I took the 62 variables and I ran, the scripts that were given to me. I modified those based on what I needed. And the purpose of this exploratory phase is to see out of those 62 variables, which ones sort of floated to the top, which ones looked to be most strongly related. So it was a mathematical approach to factor selection. And the 5 top factors that arose were intellectual disability severity, difficulty obtaining specialist care, the level of resilience in the family, the child's experience or difficulty with chronic pain, and whether the child or the parent had ever been told by a healthcare provider that their child was overweight. So these 5 factors consistently showed up as being the most strongly related out of the 62 variables that I took into the modeling. So with those 5 variables, then you go into the final modeling phase, and it produced 2 different what we call solutions, or 2 different pathways. So the first pathway showed that a child with no intellectual disability and with no difficulty with chronic pain and with a high family resilience level explained excellent or very good health. And the second solution showed that a child with no need for specialist care and having never been told that they were overweight also led to excellent or very good health. The nice thing about R and the packages that they've developed for this method is that it includes visualization. So this is something that was produced in R, and this just shows you what I basically just recited. So no intellectual disability, no difficulty with chronic pain, and the presence of high family resilience together lead to the outcome. So this would be the first solution. And then the second solution, having never been told they were overweight and not needing specialty care, also lead to the outcome. So this 2 pathway solution accounted for 86% of the cases that were included, and with 80% consistency, which is how we typically, in traditional methods, conceptualize reliability of the findings. And, you know, after we did this, we talked through it and said, does this make sense? And certainly in my, from my personal perspective, and I think from what I've read in the literature, this does seem to make sense. So we were able to reveal these combinations of determinants of health, some of which also may be modifiable, which was interesting for us to look at. And Dr. Ailey kind of brought up this concept of if you know, identifying a specific phenotype to help us guide future interventions and practices, and looking at these modifiable factors. Certainly, if someone, you know, has intellectual disability, that's not something that we can necessarily modify. But if we can work on potentially modifying family resilience levels, that could be useful for us in promoting good health. Thanks with this method with CNA is that we've noted there are over 100 CNA-related papers that have been published in the literature. There is a growing community of scholars, and they're spread all over the globe. Some of those scholars come from some noteworthy institutions like, you know, Hopkins and Georgetown. There is a supportive community if one wants to embark on learning how to do this. One of the largest communities is one called All Things Configured. It's an online group. They meet once a month. It's been running for about 6 years. There are over 200 members in that community, and they come from 15 different countries. Rush has started a new learning community as of last month, and me and Dr. Ailey are a part of that. And again, looking just to grow more practitioners in this field. Again, we think it's innovative. It can complement traditional methods, although it has been used it by itself, and it has been included in successfully funded grant applications. And I noted earlier, it can include many, many variables, as you saw how I narrowed it down, and it can also model the presence or absence of those variables. Finally, it can be used with both quantitative and qualitative data. Again, they have a different way of structuring your data. You can also use it with small n data sets. I noted one paper on CNA had a sample size of 14. So we don't necessarily have to worry about small sample sizes with this method either. Some challenges, though, are you need support in order to run this before you become independent, and you need R scripts from you know, the developers, and which can be tailored to your needs. Because it's not offered typically in courses, you know, universities, et cetera, you have to seek out your learning opportunities. There is no textbook yet, although the developer is kind of considering this. There were some researchers out of University of Washington who created an in-person grad level course this last spring. There are annual workshops and conferences in US and Europe. The next conference will be in Copenhagen next May. And there's an online course pending. It should be released sometime next spring. It was just test run by a group in Brazil. Another challenge is that can only be done in R. It is also computationally intensive because the more factors that you add, the longer it takes for the computer to finish calculating. With the number of variables that I had, from the moment I had my script clean and ready to go, it took about an hour and a half for it to finish calculating. So you have to just sit there and wait for these things to pop up and say, okay, what's going on here? The other thing, because it's an evolving method and they're constantly making new tweaks or producing new tools or new ways to measure things, you're needing to constantly update or just frequently update your software. And finally, it goes without saying, this totally bucks the norm. So definitely there are some skeptics, and I want to acknowledge that, because you know we're used to how we've always done things, but I think in the spirit of, you know, advocating for neurodiversity, for new ways of thinking, different ways of thinking, I like to take that approach that it's worthwhile to learn about these things and see if they can be helpful and useful, rather than just saying, oh, that sounds so strange and confusing. I'm gonna, you know, not pay attention to it. So for future applications, I want to see how I can integrate this into a dissertation where I look at health outcomes for autistic people who receive care in a facility where health personnel receive disability-informed education, to see maybe what program components were more effective. So Dr. Ailey mentioned potentially applying this to looking at combinations of factors that lead to diagnostic overshadowing for her new grant, and potentially looking at evaluating work that's been done with PATH PWIDD. Here are a list of references. I'm happy to share more if anyone's interested. And that is the conclusion of my presentation, and I'll open it up for discussion.